All right. Well, welcome everyone. I am Mike Levy, Chief of Vascular Medicine at Leahy Hospital and Medical Center. And it gives me great pleasure to introduce today Dr. Frank Arena, who is interventionalist extraordinaire at Louisiana Heart Center, who is going to talk to us today about a very interesting case of venous intervention that he did recently.
Great. Thank you. Thank you so much. Appreciate the invitation today. Let's go to the first slide. Next. So next slide. There we go. So this gentleman was a very interesting gentleman. He showed up to us. He was 42 years old, I believe, at the time that he first showed up to us. He had initially had his first DVT and pulmonary embolism at the age of 17 and had been on chronic anticoagulation since then. He had another one at the age of 23, I believe, and had very severe venous disease, edema, open wounds, especially severe on his left side. He was not an obese man, but he was completely disabled due to his unrelenting pain and problems with post-phlebitic syndrome. He was very compliant with his stockings and had been through multiple different physicians to try to help his problem when he finally made it across to us. On his initial physical exam, I think that was the most striking was basically he had large varicosities across his abdomen that appeared to be a caput medusa, suggesting an occlusion of his inferior vena cava. And we did an echo on him, it was completely normal. And also he had been worked up previously for hypercoagulability at the hematologist and was not found to be hypercoagulable, although, you know, it's difficult to believe that based on the extent of his problems, but that's the story.
Can I just ask briefly, it looks like they've had him on full dose enoxaparin. Was that, had they had difficulties with other anticoagulation? Do you happen to know?
Yeah, it's a good question. I really don't know the answer to that question. He was on the full dose of Lovenox. I think it was just probably because his occlusions were just so severe and chronic that people probably assumed things weren't working and just ended up going for the thing they thought was strongest. Anyway, so we did an initial venous ultrasound and could see from the infrainguinal that he had numerous areas of total occlusion, recanalization from the common femoral to the infrapopliteal veins bilaterally. And so our initial venogram, this is just, it showed an extensive intrathoracic collateral that you can see here, and basically no inferior vena cava. When I do a venous angiogram, I usually start from the posterior tibial veins at the feet, and I'll usually like to go up from there and try to cross wires all the way up and do intravascular ultrasound of the entire venous system to make sure we haven't missed anything, since venograms are notoriously difficult to interpret fully, often missing little scars and things of that nature. I like to always do a right heart cath, make sure, you know, where the pressures are, and really understand the full complexity of the venous system. So in this situation, we got in at the posterior tibial veins and everything was completely occluded. I think that probably there's the next angio on the next slide will show you. Let's go to that in a second.
Sorry to interrupt again. I know myself included, a number of venous interventionalists would typically go popliteal. Do you find more of an advantage to going sort of lower?
Well, it's not necessarily an advantage. I think the problem is that if you want to go fixing things, a lot of times if you're in the popliteal space, that 75 centimeter wall stent just isn't long enough, and you get into problems there. So I generally keep them on their back, and this way I can access the groins and put a stent in, or, you know, fix a problem that I might address.
Gotcha.
Anyway, so this is his initial venogram, and you can see that he had long segments of totally occluded vessel. This is just below the popliteal with large amounts of collaterals. His external iliac vein on the right was patent theoretically, with the common completely gone on both sides, and you can see filling of probably the hemiazygous veins, just very large collateral veins. And we worked our way across the lesions. Every level I kept working up to, I kept expecting something to open up. And it's like, surely it can't be this bad. And we kept working our way up through the IVC. And finally, I found myself at the level of at the heart, right into the right atrium. And so we did intravascular ultrasound at that point to make sure we were actually in the right atrium and not around it before we did any sort of intervention. And once I was convinced we were actually up the middle of the inferior vena cava, I was, be honest with you, at a bit of a loss. You could see the collateral ends at the hepatic vein at the base of the right atrium. So I didn't think it was a totally occluded IVC, because usually that comes in at the azygos or somewhere up above the heart. I really thought we were dealing with just a totally occluded system that was quite severe. So we did an initial ultrasounds, and I was really struck by the fact that the size of the IVC, as well as the rest of the iliac vein system, was just so involuted. It was very impressive. Much of the IVC measured 5 and 6 millimeters. So we really just used 5 and 6 millimeter balloons to basically treat this as a investment procedure, to use the CTO lingua. And we just ballooned both sides all the way down. And then basically I went out and sought opinions as to what to do with the rest of this. And that was our initial procedure. So it was very small, as you can see. Even a generous measurement was 6 millimeters in many areas. Next picture. And again, considering how severe and diffuse the extent of the disease was, I decided to back off for today and to get some other opinions from people who've seen this before, and maybe review the literature before making any decisions. And so here's our second venogram. After getting a group of opinions, I'd seen several of these cases online, and people were using Z stents, and many people were just double barreling the stents or the wall stents into the right atrium. I really didn't feel very comfortable double barreling wall stents into the right atrium because of the sharpness of the edge of a wall stent. I thought that was just a disaster waiting to happen. We didn't have any Z stents. So what we decided to use was a 10 by 20 Express LD stent, which we had, and we used that to create a base underneath the right atrium at the level of the hepatic vein. And then from there, we used another large 22 by 80 wall stent. And then at that point, we were able to start doubling the wall stents down each side. What was interesting about the extent and the course of the stents is how high the bifurcation of the left and the right common iliac veins were. They really came off at around L3, somewhere near the renal veins, which comes into play later when we try to figure out, why this happened to him. And initially, even though I put large stents in, I could really only get 10 millimeter balloons up, basically because he was just writhing in pain every time I tried to dilate up his veins to be bigger than they really were. And we were really limited by that in that first procedure. And obviously we didn't want to rupture anything either. So we just took what we could get that first day. And the plan was really to come back in about 6 weeks or so when things had scarred in, and try to make everything large enough to get a much better lumen in all the stents going forward.
And I just asked, with your initial strategy, the 10 by 25 stent, did you find, it's hard to tell from the picture, was that a big size mismatch compared to the wall stent, or did it seem to taper?
No, they looked to me they're about the same. We were able to, I think what's the difference that you're seeing is the rigidity. And this is another problem we got into with this case. I could balloon up the stent to make it bigger, but it wouldn't necessarily stay that way. The wall stent has a lot less radial force than the bare metal stent does. And so it doesn't, it just collapses under the pressure, under the external pressure, which was a frustrating thing and a challenge going forth in the case over time.
And none of the
So
new May Thurner type stents would be
I'm
big
sorry?
enough for this. The Vichy or others, I suspect they wouldn't have been big enough for what you wanted to do.
Well, yeah, well, again, the VC really doesn't have a lot of radial strength either. I think the wall stent probably has more radial strength than the VC. But what I would love is if they would make me Supera stents in a large size. And I've been asking them for a while to do that, but so far, no help. I think that would have been very useful to us in this case. Anyway. So we came back a couple of months later, and he was actually doing fairly well. And the right side was completely patented, looks fantastically. Now the left side here, as you can see, was closed for a short distance in the external iliac vein, and it developed this large collateral around it. I think, you'd like to admit your mistakes in life, so people can learn from them. I think my mistake was right here in this case. I think I should have just left this alone. It had great collaterals. A stent closes basically because the collateral network around it has better flow than the stent. And I should have left it. I should have just taken care of his superficial veins at that point, dealing with his wounds, and left him clinically doing well. But that's not what we did. We went after it and opened it back up again, and repeated the angioplasty with 14 mm balloons, thinking, on the original plan to open up the stents as large as we could. Next slide. And here was our IVUS. But again, despite being very aggressive with the balloons, pushing them up as high as we could, and definitely getting them to deploy, you can see that the size of the stents are very small. And it's really all the external compression from the fibrotic veins that are really keeping the stents from obtaining really solid sizes. And again, I think we'll talk a little bit later of my theories of what causes this. I think that left side particularly is probably hypoplastic. Anyway, he was discharged of full dose anticoagulation. He did fairly well for about 15 months. And then he represented with symptoms of venous hypertension and some new wounds on his left. And he had been a compliant guy. He's a good patient. So he had not done any of these things himself. Things just didn't work out for him. Next slide.
So he was placed back on his Lovenox?
No, he was placed on, I believe he was on Pradaxa. And this is probably, this goes into it. I'm pretty sure he's on the Pradaxa because he has an allergy to Eliquis and Xarelto.
I see.
He has some sort of problem with that. Anyway, so he was discharged with full anticoagulation again. And unfortunately, within weeks, his symptoms recurred again. So we were up for another venogram. And you can see here, on the right side, things were fine. This time we did come from the popliteal vein on the left. And you can see we lost a fair amount. This is why I say I should have left well enough alone. We had these nice robust collaterals that had drawn in. But you can see the femoral and popliteal segments had maintained fairly well with their balloon result, but we lost at the common femoral, which was actually a very big deal, I think. So we worked our way across the lesions, and we used some Athleta balloons. And that is kind of an interesting point, is that you really have to be prepared to use very strong balloons when you're working within these wall stents. They will pop the Conquest, they will pop the Athleta balloons, and they will just destroy a regular balloon. So really the Athleta being it comes in a 135, is pretty much your go-to balloon with these type of, and you better have a lot of them with these type, when you're working with these kind of stents. They're so sharp at the edges. We ballooned up to 10 and 12 millimeters again. And we still had our same IVUS problem this time of no matter how much we ballooned it, it would just compress back. So this time I decided we were going to try to use bare metal stents, and we used 3 10x37 bare metal stents to support and enlarge the lumen. And that did work to overcome the external forces. We were able to dilate to 12 millimeters or so and get more patency. We used another 18 millimeter wall stent into the common femoral distally to ensure inflow and try to get good inflow and outflow. And I thought we had a pretty good result on that. Although again, I wasn't crazy about how far we had to extend the stent down across the common femoral, which comes into a problem later. So he was doing fairly well. He went back to his normal activity. He's no longer disabled, doing very well, has a job, and his family's improved. He still had a Villalta score of 15 because he had an active wound. So our next goal was just to go after the superficial varices in his left lower leg. And there was an area of his GSV and a perforator vein in the lower leg. I didn't want to take out the entire GSV because that flow was feeding this. It came in the side of the common femoral vein stent and it was feeding that system. So I thought I would just take some cryocyanolate and close that segment right there, and that would hopefully take care of the problem without obstructing the stent. That was my plan, at least. I didn't really want to do excess phlebectomy because that was going to create more wounds. And so I thought I could always come back later and do phlebectomy if I had to. I thought this was the safest plan, basically. So unfortunately, plans are great, but they don't always work out. So we came in for his 3-day follow-up after the GSV closing. And even though the plan went perfectly, we only took out the part of the greater saphenous below the knee, and we went up to a branch point, so there was flow into the GSV and up into the stent. He still managed to close down the stent. So at that point, we rushed him over to the hospital again, and his superficial system looked great, but now we had a problem at the above. So this time we came from above. Well, this is another picture showing the GSV coming into the stent and our procedure from that day, just if I didn't explain it well enough. And again, we didn't use sclerotherapy out of concern of DVT, and we didn't do phlebectomy to avoid creating additional wounds. Next slide.
Can I just ask, at the time that you had done the ultrasound just prior to treatment of the GSV, did the sort of common femoral waveforms, were all those okay at the time?
Yeah, they were. They were. Everything was pretty well. It moved well with respiration, and everything looked pretty good to do this. So this time we came in. Oh, this is the same thing showing that the GSV is patent in the thigh, but no flow at the level of the stent. There we go. So this time we came from the right brachial approach, brought down 8 French by 90 sheath, and did a power process angiojet with 10 milligrams of TPA, and tried to open everything up, again using 12 millimeter balloons to get the stents as large as possible. The occlusion, thankfully, was confined to the stent, and the previously open femoral veins had remained widely patent. We got a nice result. And so far, he's been doing fairly well. That's just a shot from the inflow veins coming in. So this was interesting. So we did have some clot from the power pulse that we managed to move a little bit, unfortunately, that got into this is the area where the 2 stents double barrel into the single stent in the mid-abdomen. And so we IVUSed it. We could see there was a significant, probably chronic piece of thrombus right there. So we did a little additional power pulse on that and managed to clean that up very nicely, but probably cleaned it up by throwing a little pulmonary embolism because he had a couple of seconds where he was feeling fairly poorly, but nothing really significant happened. But it does show that you can have some episodes of issues when you're dealing with these kind of problems. Next. Anyway, so at this point, it's been, since I wrote those slides, it's been 2 months, but now it's been about 5, and he's doing very well. His stents remain patent. We've been ultrasounding him every month or so in the office. I think we do have some issues going forward in that he does feel that stent some when he bends too much on the left. And so I am concerned that he's developing a negative stent interaction, and basically, as he keeps bending it, he'll continue to create scar from basically the micro trauma of bending against a rigid stent. And so we're going to keep a close eye on that. And again, I'm hoping that somebody from Abbott will watch this and make us some 10 and 12 millimeter stents that would be nice for a bend point at that position, the same as we use in the SFA. But this has been a challenging case. And like I said before, I think the thing I would have done if I had thought about everything again would be to left it alone that first time and treated him clinically and made sure that that he was good enough rather than perfect. The enemy of good,
Absolutely.
Anyway, so that's this case. It was a very interesting case. The only time I've ever seen this. So we have a question.
I'm sorry, before you get to the question.
Sure.
Was he discharged also on Pradaxa, or was the anticoagulation changed?
No, he's still on Pradaxa.
I guess one question I had is, given that he had sort of given that he was on Lovenox, presumably at full dose, and then switched to Pradaxa, and then he had those issues with sort of thrombosis, was there any sort of discussion about a different anticoagulation that you could sort of follow, like either Lovenox or Coumadin, just to make sure that the therapy was sort of what you hoped it was?
Yeah, I didn't really consider that. I mean, we certainly could. I was hoping to make things as easy as we could on him, but certainly that would be a possibility, something to consider in the future. I tend to find that at least in my experience, it's not so much the quality of the anticoagulation, it's the quality of the flow through the stents. That is the problem, as you know, they can take all the anticoagulation they want, but if you don't have good flow, it's closing down.
Absolutely. If you knew, let's say you knew from the outset that he had a thrombophilia, would that have changed anything for you during the case, or do you think you still would have gone through the same approach?
Yeah, I think if he had a significant thrombophilia, you could consider Coumadin at a higher level at that point. You could consider adding something else like an antiplatelet to the regimen. That would be pretty reasonable. Maybe a PAR1 inhibitor that might be interesting to try. I don't think there's any really good data on this kind of thing other than increasing the Coumadin. Which is what I think most people would tend to do. Just put them at a 3 to 3.5 INR, treat it like a valve.
Interesting.
What do you think?
I agree. I think my gut feel about the beginning of the case, just as sort of the fact that it had those sort of VTE episodes at a young age. I agree with you, sort of your comment that even though hematology had said no thrombophilia, it just seemed a little suspicious. And yeah, I agree with you as well. I think at some point I would have considered either Coumadin at a higher target, or maybe even Lovenox at a higher target following 10A levels, depending.
I think that's reasonable. We can certainly do that. Yeah, we can certainly do that and see if that improves the situation,
But that was a very impressive
right now, he's pretty stable.
Excellent. And his wounds had healed, you'd said.
I'm sorry?
The wounds had healed.
Yes, his wounds are healed, and he's doing very well. He's actually very happy about the whole situation right now.
Fantastic.
So, yeah. But it's interesting, he still has those veins across his belly. They never resolved, so that was interesting. Anyway, so getting to etiologies, initially I was thinking, well, he must have had a Budd-Chiari or some sort of membrane across the top of this and some sort of hypercoagulation when I first met him. But He didn't, like I said, diving into it, he didn't have the hypercoagulability. And I think the more I looked into the etiology of this, I was struck by how high the veins come in. And so I really have to believe that this is a persistent left superior vena cava. And there is description in the literature of when the left superior vena cava comes in below the renal veins, that it often is a hypoplastic situation. So that's really what I'm thinking, that why we're having such problems on that left side is because it's really a hypoplastic vein to begin with. And it's just become more problematic because of that. Do you have any ideas about what might have caused all this?
I think that's a very reasonable thought, especially sort of as you say. It just seems very typical that the confluence would be that high up, and so the fact that he still has that prominent veins, it makes me wonder. Certainly,
right. Yeah, he's a good patient. He tries hard, and he's been very pleased that he finally found somebody was actually able to help him. So I'm sure it'll be an ongoing thing with him, but it's just the way some people are. You just have to work on them. But I think it's a good suggestion about the Lovenox. Maybe we should do that. I'll discuss it with him next time he's in the office. I think I'm going to rerun all of his hypercoagulability studies as well, just to make sure something hasn't been missed.
that'd be interesting.
Yeah. Okay. So these are some of the slides, if people are interested, of some of the more common anomalies of the inferior vena cava, duplicated IVCs and left-sided IVCs, and some of the lesser ones were duplicated renal veins and renal veins that come around the circumaortic. And so I guess the learning points was that the small sides of the veins become a real challenge when you're treating them. And again, the point with whenever you're putting stents in veins is if your collaterals have more flow than your stents are going to close. So you have to find a way of making your stents big enough. And I'll be honest, this is the first time I've ever had to put bare metal stents in a wall stent to try to make it extra big. But it does work, and sometimes you have to do that. And even though the stents look like they're reasonably open, when you IVUS them, that's the real issue and the real size of the vessel. You have to have good flow or things just don't stay open.
In terms of sort of indications for this extensive venous intervention, are these ones you're taking on sort of really just in patients that are advanced stage, so patients with non-healing ulcers, or do you consider sort of any other cases with sort of more symptoms, or I guess sort of less end stage disease in young patients?
Yeah, that's a good point. I think you have to, like, I was very worried initially, if I open this up, am I going to disrupt the organ perfusion, And so that was my first thought. It's like, okay, if I do this, am I going to lose a kidney, or what's going to happen here? And after I talked to a few people, they're like, well, it's never happened to us, so I don't think it's going to happen. And because they developed the other collateral. So that was one thing that put my mind at ease. But I think that if a vein system has collateralized very nicely, and it's not causing a lot of trouble, as we've learned, you can make things worse sometimes. And so it's just generally not a good idea to treat anatomy and not treat the patient. So I think that, when you're dealing with people with, very severe post-phlebitic syndrome and ambulatory venous hypertension, the kind of things that are just really ruining their lives and make it so difficult for them to just lead normal lives. Those are the people who want to take a risk. And they're willing to take a risk. But if you have somebody who's looking at you and they don't even know they have a problem, like somebody with a completely occluded IVC, just congenitally, I think doing surgery or whatever you would to repair that doesn't make a ton of sense to me.
I agree with you 100%.
Mhm.
And a sort of a side question that I always love to ask venous interventionalists. So in patients with, say, more classic May-Thurner, where you really demonstrated compressive physiology, you stented sort of whatever stent of choice, what is your strategy sort of beyond that in terms of either anticoagulation or antiplatelet long-term?
Right. Yeah. I'm pretty cautious on that. And I know a lot of other people don't do this. A lot of people are just aspirin and Plavix, and they're very comfortable with that. I keep them on, full dose anticoagulation for a few months until I'm comfortable. This thing has had opportunity. Whatever can endothelialize will endothelialize, and things are stable. And then I'll switch them over eventually to aspirin and Plavix. But I will keep them on full dose anticoagulation. Let me ask you a question. This is a different question. So we got the back and forth here. I had a lady. In fact, I just saw her today. I did a Venogram. She was complaining of chronic swelling in her left leg, and I suspected she had a May-Thurner. And I did my usual Venogram and right heart cath and everything. And of course, all she had was a May-Thurner. But she's in her early 30s, and she's planning on getting pregnant again. And I told her, I don't think I'm going to put a wall stent anywhere near where a gravid uterus might be laying. You come back to me when you're done, having babies, and we'll talk. And I don't know anybody else. I've never really asked any other experienced venous interventionalist what their thoughts are on this. It's just my own personal opinion. That makes me nervous.
Did she, and she got through her first pregnancy with that issue?
Yes.
No.
Yeah, but that was many years ago. Her daughter was sitting next to her, and she was like 13, and the lady's 33, so she was 20. So I think the second pregnancy probably will be a higher risk situation. So I think I know where you're going with the anticoagulation question here.
That's
But
very
that was going to be the next part of it.
And you were saying the indication for workup was really just some chronic swelling.
Yeah, chronic
Not a
swelling, and
DVT.
when she walks, she got a little. She gets a little ambulatory venous hypertension when she walks, and it was just bothersome to her. She didn't really have any varicosities of consequence or GSV insufficiency. She's had no previous DVTs, but it was just the kind of thing that was bothersome to her. And one of my partners sent her over to me, and we did the whole thing. And she had a very severe compression. It was the real deal, but I just thought we'd put it off a few years. And
yeah, I think that's actually a very interesting question, and I can think of colleagues that I know that would be on both sides of this. Some
right.
would sort of take your approach, which actually I think I'd be more inclined to do, given her young age, given the fact that she's not truly had an event. And then I do have some colleagues that would sort of counter and say, well, she's got severe compression. If you were to sort of place this, that may sort of help prevent, events during the sort of peripartum period. But, I think a lot of this is really data free.
Right, exactly. It's all speculation.
Absolutely. I think the ones that I have treated, actually, all of them across the board have been ones that have had, it's always been post-event.
Right.
They've had an extensive DVT, we've proven compression. Then I feel sort of more comfortable. And then I'm also having them on more sort of prolonged anticoagulation as well. So I think, that sort of helps me make the decision a little bit more. But yeah, I agree with you. I am a little more hesitant in younger patients who have not had a true event and either just have some sort of a symptom or some swelling that's not particularly debilitating. I agree with you. I would take the same strategy.
Great. So that leads to the next question. Do you think she needs extra Lovenox later in the pregnancy, in the third trimester, or something along that lines?
It's a good question. It sounds like she's someone who, though, could remain active and is ambulatory, and
right.
I think, potentially just with some education about, what her disease process is, I wonder that you'd probably be okay. I guess the one thing I would wonder about, though, around sort of the time of delivery and just afterwards, would it be worth, or at least after the delivery, would it be worth some sort of anticoagulation, even prophylactic? something of that nature. It's a tough one.
I'm sure I'm going to get this from the OB. So I think just my recommendation, I think, is going to be to once things get really moving along, to do maybe 40 a day of Lovenox. I don't think that's a bad thing, you know.
Yeah, I think not unreasonable. Though it sounds like her track record is she had done okay previously,
Right.
but
She
I think
has.
that's reasonable.
She has. Okay, great. Well, those are my thoughts for the moment.
Just this has been a fantastic discussion. Just last question. You had mentioned sort of transitioning from anticoagulation to antiplatelet in the May-Thurner patients. Is that lifelong for you, or do you eventually drop it down to single antiplatelet or nothing?
Right. And that's a good question. And now, some of it depends on the stent. A lot of times with the May-Thurner, you have to put the stent all the way up into the IVC. And that stent is never really going to endothelialize well. You're always going to have metal exposed, which is, I mean, I think I'm more amazed that most of these do well
Right.
than that they don't. And I would love some, clear data on that. But I would keep them on aspirin Plavix at least as long as they could tolerate. And that'd be the way I go. Now, if it was just a short segment that was completely encased in vein, that would be maybe a different situation. But most of these are up into the IVC, and there's always metal exposed to blood. So I think I would, generally, I'm one of these people, if it ain't broke, don't fix it. So I'll end up leaving them on it.
I think that
But I
makes
have no data, obviously. I have no proof. I just don't want complications.
I think that makes a lot of sense. I've been a fan of sort of extended lower dose anticoagulation.
Right.
In my
I like that
patients.
too.
So far, that seems to have played out pretty well.
Right.
I did think of one last question for the experienced venous interventionalists. The few cases I've seen of ISR in these venous stents, I have had just a bear of a time trying to deal with that. I don't know if you have any sort of advice or tips or tricks that have worked for you in the past.
I mean, I have a few people that are nightmares like that. I mean, literally, I mean, you know what, to cross them, a laser melts through them. Otherwise, you will literally be taking the stiff end of the stiff glide wire with a 45 or 55 sheath from the popliteal up against it and jabbing at that thing, trying to cross with a sharp dissection technique, and you will still be extremely frustrated by your inability to get across that, especially in places where there's two stents overlapping, and it's created a particularly nasty scar. So usually what I'll do if I get something like that, where it's just scarred in so firmly that it's just unreasonable. And sometimes you get this in the subclavians in end-stage renal disease people who've had SCAR, and those are just horrendous cases, is I'll take an angled catheter with a laser and I'll just try to go up the middle of it. It's an interesting thing. It's what we used to do before we had the Pioneer in the common iliac artery total occlusions. We'd take the stiff end of a wire and a IVUS catheter and bring it up an IMA guide and just make sure we stayed in the middle of the vessel and just kept poking forward till we got to the edge of the aorta where the cap was, and then pop through it. And that's how you'd get up before you could get a Pioneer. That was just makes common iliacs easy now.
Sounds like MacGyver.
Yeah, well, back in the day, you had to do what you had to do, And so now it's so with these, I'll pretty much do the same thing. And a lot of times you'll get these in an old stent that'll be occluded and it'll be just like rock. But sometimes, like I said, in the subclavian veins, you'll get them in people who have end-stage renal disease. And I'll get them where, for some reason, the vascular surgeon decides to put a AV fistula on the side where the subclavian vein is known to be totally occluded. And all of a sudden, the guy will have an arm the size of my leg, and we'll have to find a way across it. And those can be particularly tough cases, but the laser is the key, I think, to crossing them, and just staying in the middle, using your IVUS a lot, knowing where you are in your position, and just, patiently working across it until you can get a wire across it. And then, you can laser a little bit bigger, but ultimately you just have to get a big tough balloon and a couple of big tough stents, make them big. But that's basically what I would do.
Well, thank you. That's fantastic. And also thank you for an excellent presentation and an amazing case. That was really
Oh, thank you.
a
That
tour
was
de force.
I hope somebody can learn from our trials and tribulations here,
Absolutely. And thank you for the discussion. This was really great.
All right, fantastic. Thank you so much.